Hi, my name is Aubrey Jones, and we are going to talk about ischemic heart disease, which is a condition, and angina, which is a symptom that is enticed by the condition of ischemic heart disease. First, to define different types of ischemic heart disease, we first have stable coronary artery disease and then unstable coronary artery disease. Within stable coronary artery disease, we have chronic stable angina. Within unstable coronary artery disease, this is better known as acute coronary syndrome, which is whenever a patient has a myocardial infarction or an MI, better known as a heart attack, which can be classified as either unstable angina, an NSTEMI, or a STEMI. We're not going to spend time on any of those things, but I just wanted to go over some of the definitions. They will be mentioned throughout this presentation. And the main point is I want you to identify the differences between stable coronary artery disease and unstable coronary artery disease. So in coronary artery disease, this is typically what happens in a patient. So we have the arteries of the heart, and you can see that over time we get some portion of plaque buildup. And so in a stable plaque, which is stable coronary artery disease, we have a thick fibrous cap here. It's very intact and it's stable. In unstable coronary artery disease, this plaque becomes loose and can potentially rupture. And whenever this ruptures, platelets come and our clotting cascade starts. It's completely clotted off and it leads to an acute coronary syndrome. So to prevent something like that happening, we first look at non-pharmacological treatment options, so diet, physical activity, a lot of the things that we see in regards to any type of heart-healthy living style. So if that plaque does progress and then rupture, the first thing that comes in are platelets, and then after that the clotting cascade comes into effect, and eventually the entire artery becomes blocked off and we have an acute coronary syndrome. So since anticoagulants were covered in a separate lecture, I'm going to spend some time talking about antiplatelet agents. They all target different sites on a platelet, so you can see that this is a kind of a rough diagram of what a platelet looks like. It's pretty complex. There's a lot of different binding sites, and so the different agents target different types of sites within it. For specific antiplatelet options, we first have aspirin, which inhibits thromboxane A2 and prevents platelet activation. We also have our P2Y12 inhibitors, which inhibit the ADP binding, and they as well prevent platelet activation. Lastly, we have our glycoprotein 2B3A inhibitors, better known as GP2B3A inhibitors. These actually, instead of preventing platelet activation, they prevent platelet aggregation. So aspirin specifically, which is probably the most common antiplatelet that you'll see, is indicated in a lot of different settings, specifically acute coronary syndrome, like I just described, as well as being indicated in chronic stable angina as primary prevention of an acute coronary syndrome, as well as in ischemic stroke or patients that have had a TIA. The dosing is anywhere from 81 to 325 milligrams, but most of the guidelines have been updated to include that 81 milligrams is sufficient for most, if not all, indications, with stroke being the only exclusion. Side effects for aspirin, of course bleeding, but more specifically GI bleeding is the most common form of bleeding on aspirin, followed closely behind epistaxis or nose bleeding. One important thing to mention is that with an aspirin overdose, one of the most common symptoms is tinnitus. There's also a combination aspirin product, aspirin and diprodamol, known as Agrinox. Its only indication is for secondary prevention of stroke, so you won't see it in your ACS or angina patients. The side effects of this specific agent include headache and intracerebral hemorrhage risk. All right, we also have our P2Y12 inhibitors, which should be used for 1 year after an ACS event. We have clopidogrel, prasugrel, and ticagrelor. I won't spend too much time talking about the differences between these. The one takeaway that I want you to know, though, is that ticagrelor specifically can't be used with any dose of aspirin higher than 100 milligrams. So if you ever see a patient on a 325 aspirin and ticagrelor, this actually decreases the efficacy of this life-saving antiplatelet agent post-ACS event. The indications of our P2Y12 inhibitors are in ACS or acute coronary syndromes, as well as during actual PCI or percutaneous coronary intervention. They're also potentially indicated in CVA or TIA. Clopidogrel is the only one with this indication, and it should be used in patients that have an aspirin allergy. Something interesting is that P2Y12 inhibitors as well as aspirin have a duration of action of 5 to 7 days after discontinuation, and that's because they bind to the platelets and deactivate them, and a platelet's lifespan is about 5 to 7 days. Side effects of these, of course, are bleeding, and then ticagrelor offers an additional side effect of shortness of breath. For completeness, I'm going to briefly talk about our GP2B3A inhibitors. The agents are abciximab, eptifibatide, and tirofiban. You only really see these used in the hospital setting. There is a very high bleeding risk with these agents. So in our patients with ischemic heart disease, antiplatelet treatment consists of aspirin plus a P2Y12 inhibitor for 1 year if the patient just had an ACS event or an acute coronary syndrome. If a patient has history of ACS, so they have history of an acute coronary syndrome, then they should be on aspirin indefinitely. And then patients with stable angina, aspirin can or cannot be used. It's really a risk versus benefit. I would say majority of providers go ahead and use aspirin, but it's a little bit more flexible here if the patient's at a high bleeding risk. So what a lot of people do is they calculate the ASCVD risk, and if a patient's at greater than a 10% risk, and they're aged 50 to 69 years old with just stable angina without some sort of acute event, then they'll go ahead and use aspirin. And this is a calculator you can look up online and just put in the patient's factors and be able to calculate how at risk they are of an acute event. And so going back to this picture of what a plaque kind of looks like, if this plaque never ruptures and becomes unstable, then we're looking at a patient with a stable plaque and therefore stable angina or stable coronary artery disease. We're looking at treatment of the angina alone. And angina is a clinical syndrome characterized by deep, localized chest, jaw, or back pain that is reproducible with physical exertion. And that part is very important whenever you're working with a patient and trying to identify typical versus atypical chest pain. Angina is relieved by nitroglycerin or rest if it's going to be chronic stable angina. If it's not relieved by nitroglycerin or rest, then it is potentially more of an acute situation that they should go to the hospital for. So therefore, this angina should be reversible, and if it's not, then it is a medical emergency. There's really only two etiologies of angina, either atherosclerosis or vasospasm. With atherosclerosis, this is due to fixed coronary stenosis. So the picture that I showed you earlier of that plaque just building up, this impairs coronary flow to your heart, and therefore you get demand ischemia because of the lack of oxygen supply. With vasospasms, there's actually just a constriction of non-obstructed coronary arteries. Sometimes this can be due to patients that have extra electrical stimulation to the heart. And then there's also a combination of both the two. And so therefore, the pathogenesis of angina really is a mismatch between supply and demand. So the definition is really just an increased oxygen demand that is unmet by oxygen supply. Some things that lead to an increase in oxygen consumption include an increase in heart rate, an increase in wall tension, or an increase in contractility. So the medications that we use to treat angina really target one of these three mechanisms. Here's a list of the different symptoms and risk factors for ischemic heart disease. The symptoms are pretty specific, especially in regards to chest pain. It is a chest pressure that radiates to the back, shoulders, neck, throat, or jaw, and sometimes down the arm. And specifically in women or older individuals, they can have some accompanied nausea, vomiting, and those are the atypical symptoms of ischemic heart disease. And then risk factors are very similar to risk factors for cardiovascular disease in general. Specifically, though, sedentary lifestyle and obesity kind of sit at the very top. So just to summarize real quick, before we jump into the different classes and how they target angina, for pharmacologic treatment, there are agents that have been shown to reduce the risk of myocardial infarction or that acute coronary event, as well as death. And so we already reviewed the antiplatelet agents and how they're used in the acute setting. The other one that I really wanted to mention are statins. So statins should be used in any patient that has either stable or unstable coronary artery disease. And that's to prevent the risk of death and the progression of the disease state. I don't have a slide specifically on statins, so I highlighted in red because it is very important to remember. Beta blockers and ACE inhibitors and ARBs also have an indication to reduce the risk of mortality in patients with a history of ACS or a history of an acute event. Agents that specifically only reduce angina, beta blockers do both, but we also have calcium channel blockers, long-acting nitrates, and ranolazine that specifically only target angina. So in summary, in patients with ACS or an acute coronary event, they should be on aspirin and a P2Y12 inhibitor for 1 year, then aspirin alone indefinitely. They should also be on a statin, and then they should be on a beta blocker and an ACE inhibitor to decrease their mortality. Patients with stable angina should be on aspirin, weighing the risk versus benefit, as well as a statin, and then they can use beta blockers, nitrates, calcium channel blockers, or ACE inhibitors to control their symptoms or underlying comorbidities. Beta blockers are the drug of choice for chronic stable angina. It's important to mention that they only reduce myocardial oxygen demand, and they don't do anything in regards to myocardial oxygen supply. They do this by decreasing the heart rate, force of contractility, and the conduction velocities. It's also very important to mention that they do reduce the risk of death and MI in patients that have had a prior MI or ACS event, and atenolol and metoprolol are the most commonly used. Now, I want to specifically talk about versus our cardioselective beta blockers. So if a patient has history of asthma or COPD, we really should preference using our cardioselective options. So those like metoprolol or bisoprolol that are beta-1 selective. Otherwise, unlike heart failure, in patients with ischemic heart disease, we can choose pretty much any beta blocker and they work just fine. For calcium channel blockers, they're really second line behind beta blockers unless the patient has vasospastic angina, then they become first line. They work both by reducing oxygen demand and increasing oxygen supply, but it really depends on which class you choose to use. So if you use your DHPs, so amlodipine or felodipine, they work in your peripheral vascular system, and therefore they're increasing your oxygen supply. Your non-DHPs, like diltiazem or verapamil, work directly on the heart by decreasing your heart rate and contractility, very similar to beta blockers, and so they're reducing your oxygen demand. For your nitrates, they definitely work on both your oxygen demand and your oxygen supply, and these are really your third line agents because of adverse effects. And so they work through vasodilation throughout your entire peripheral vascular system and, like I said, affect both supply and demand. So the concerns with nitrates, first and foremost, is the headache that is associated with them. Secondly, there is something known as nitrate tolerance or nitrate tachyphylaxis. The mechanism for this is not clear, but the solution for this is to provide patients with a 6 to 8 hour nitrate-free interval, and this is usually done overnight. Lastly, and most importantly, is that nitrate should never be used concomitantly with phosphodiesterase inhibitors, so those like sildenafil or Viagra, because we get extreme hypotension and concomitant use of the two are actually contraindicated. Ranolazine is our last line option, and this is primarily due to adverse effects. It should only be used in combination with either a beta blocker, calcium channel blocker, or nitrate. And interestingly, although this is an anti-angina medication, it's actually also an antiarrhythmic and works through the sodium channels. So with the adverse effects, the most common ones are nausea, dizziness, and constipation, and this happens in about 25% of patients. There's also the adverse effect of QT prolongation. The last medication are our ACE inhibitors, so they're not necessarily anti-angina medication, although they do help with symptoms by decreasing your oxygen demand and increasing your oxygen supply. But the reason that these agents are used in our ischemic heart disease population is because they help prevent MI and death and remodeling of the heart after an acute event. And just remember that ARBs can always be substituted whenever a patient is intolerant to an ACE inhibitor. Lastly, I want to touch briefly on peripheral vascular disease because it kind of falls into ischemic heart disease, but it's really ischemia in your peripheral vascular system. And so with PVD, it's also referred to commonly as peripheral arterial disease, although peripheral vascular disease includes both your arteries and veins. Peripheral arterial disease is the most common, and so sometimes the terms are used interchangeably. This is a condition that affects the lower extremities, more specifically your legs, and complications include leg ischemia, intermittent claudication, and pain. And intermittent claudication is really just pain when walking. For diagnosis, you use Dopplers or your ankle brachial index. For treatment, all patients with PVD should be on an aspirin and a statin, and all patients should stop smoking. It's the most major risk factor and leads to severe progression of the disease. Interestingly, in regards to the medications that you can use, you must stop smoking before you can even trial either of the medications. And whenever it comes to selecting between psilocybin or pentoxifylline, it's really just important to consider patient factors because, as you can see, you would want to avoid psilocybin in patients with heart failure and potentially avoid pentoxifylline in patients with history of MI.
Low-dose rivaroxaban was studied in the COMPASS trial in patients with stable coronary artery disease and peripheral artery disease. Rivaroxaban 2.5 milligrams twice daily in conjunction with low-dose aspirin was found to decrease the composite of cardiovascular death, stroke, and MI by 24%. It was also found to decrease the risk of major adverse limb events in patients with PAD by almost 50%. The use of rivaroxaban and aspirin, however, did increase the risk of bleeding when compared to aspirin monotherapy. As a result, low-dose rivaroxaban has been approved by the FDA in 2018 for this indication.